We're now going to switch over here to personalizing your melanoma treatment. So I'd like to introduce Dr. Amatruda, a wonderful medical oncologist up at Minnesota Oncology.
Thank you so much, Meredith. Well, I really appreciate the opportunity to take part in this session. It gave me a chance to think through some of the aspects of cancer treatment that I've encountered over years. I started medical oncology back around the time gene cloning was invented. So it's been a wonderful change over the years. And I've really enjoyed the chance to work with the enthusiastic young people in Meredith's group and Sarah Cannon, who have a passionate desire to improve care of melanoma. So I'm going to talk about personalized treatment for melanoma. And I realize there's two aspects of this. There's treatments based on the unique biology and vulnerabilities of the cancerous tumor, and basically personalizing our understanding and attacking the tumor. And there's also treatment decisions based on unique history, strengths, and vulnerabilities and wishes of the person being treated. And I'll touch on that at the end of my talk. I'd like to start by just talking about what defines a cancer cell. The diagram's on the left. The key thing is that it has unregulated growth. It may be fast, it may be slow, it may be very orderly, it may be destructive or innocuous, but the key thing is that it's an abnormal growth compared to normal tissues. Cancers may grow locally, it may spread and metastasize, it may respond in part to normal regulatory factors. Cancers also represent a community of cells. There are cancer cells shown here in the brown, but mixed in with those will be immune cells, fibrous cells, blood vessels, and the cancer cells and the surrounding cells all change over time and change with treatment. The smallest tumor that can be detected on a PET scan or CAT scan is about 5 millimeters, and yet that tiny tumor may contain more than 10 million cells. And that explains some of the difficulties in treating this disease, because successful treatment requires essentially an extinction of an entire population of cells. Cancers from a given tissue have characteristics of that tissue, and these can sometimes be used to treat the cancer. One of the earliest examples is that lymphoma cancers express a surface protein called CD20, shown here on the surface of a lymphoma cell. And antibodies were developed that bind to that protein and bring immune cells close to it and also recruit attack by other parts of the immune system. And this is a treatment that's been used for many years now called rituximab. More recently, a modification of this approach has been developed where antibodies are developed that bind to surface proteins and also have tagged onto them potent chemotherapy medications. So the chemotherapy medications are attracted just to the target tumor, bought inside, and can kill the cancer. And this is a growing area of medicine, essentially personalized to the particular surface proteins present on the cancer cell. So another aspect of cancer cells are in a hurry to grow. They don't repair damaged DNA, or they can't repair it. For example, Burkitt's lymphoma cells always have to grow. And so if you give them chemotherapy, they all die. And short course intensive therapy for Burkitt's lymphoma works on the principle that the cells cannot repair their normal DNA, whereas normal cells can stop growing, repair the DNA, and some cancer cells cannot do that. So that gives some of the principles of cancer therapies. The first is to remove the cancer before it recruits a blood supply. And that gets back to what Meredith talked about. For melanoma, one of the most important things we find is for people to get in quickly to dermatology if they have a mole that concerns them or a changing mole. And we found that the dermatologists have helped us a great deal by setting up short interval visits where somebody can come in and just have a mole looked at. It takes months to get in for a full dermatology appointment, but you can get in for a week. If you say there's a mole that's changed or is bleeding or is giving me concern. So surgery is the key aspect. Another aspect is to target the behavior of the cancer cell and essentially damage the cell more than normal cells. It would be with chemotherapy or radiation therapy. And in the old metaphor, the treatment of cancer would be slashed with surgery, burned with radiation therapy, or poisoned with chemotherapy. Grim, cynical, but it's a lot easier to be cynical when you're not faced with a growing cancer. And these treatments above have prolonged lives and cured many cancers. However, many cancers like melanoma are more wily. They can mutate to become resistant to chemotherapy. They rapidly engage with blood vessels and can spread into the body. And if you remember Meredith's diagram, the melanocytes move into the skin and sort of are visitors to the skin, and they have the capacity to travel through the body because they originally came from the neural crest of the embryonic system. So that's why melanomas are much more dangerous than other skin cancers. They have the propensity and the ability to travel in the body. Cancer cells can also go into rest phase to hide from chemotherapy, unlike the Burkitt lymphoma cells. And remember, if there's 10 million cells in a little focus, only a small proportion have to survive to give trouble. So one aspect of personalizing the treatment of melanoma is the surgery. So the type of surgery done for melanoma is based on the depth of invasion of the tumor to remove a certain margin of normal tissue around it, and then to look at the lymph nodes that drain that area of skin, really for any melanomas of greater than 0.8 millimeters in depth. Shallow melanomas of stage 1A can just be followed by dermatology without a need for medical oncology follow-up or imaging because they're very unlikely to recur. However, deeper melanomas, we often consider ultrasounds and CT scanning to look for recurrence, and we often will consider immune therapy to prevent recurrences in these higher risk stage 2C and early stage 3 melanomas. Stage 2 and C melanomas are basically deeper melanomas in the skin. Stage 3 melanomas are melanomas that involve the lymph nodes. Now, wouldn't it be better? Can we do better at predicting the risk of relapse after surgery? And there's been work recently on developing gene expression profile tests that essentially fingerprint the tumor to predict the prognosis. There's a Castle test, there's a Merlin test under development. These tests can guide intensity of the follow-up and potentially guide the use of other therapies to prevent recurrence. And this is just a slide, and I'll sort of take you through the slide a little bit. Many of you will be familiar with this. This is a curve that shows the results of how many people, what proportion of people have a recurrence of the cancer over time, 2.5 years, 5 years, 7.5 years, 10 years. This group of people in the blue, identified in the blue line, have a low risk gene expression profile and stage 2 melanoma. These people with the brown line had a higher risk pattern of expression. And what you see is that by 10 years' time, about 75% of people with the low risk pattern are free of melanoma, whereas only about 50% of people with a high risk pattern are free of melanoma. So if we can use these tests, we may be able to follow these people without further immune therapy, yet these people may be benefiting from other therapies to try to prevent recurrence. And work is underway to refine these tests to get a more personalized understanding of the risk of melanoma at the time of diagnosis. But what about, can we treat cancers better by knowing and targeting their mutations and their growth pathways? And this slide here shows that the normal, I can't really read the top of it, the normal growth patterns of melanoma, normal growth control pathways in cells are disrupted by genetic mutations in cancer cells. Different types of mutations cause abnormal growth. One would be an oncogene, where mutation results in a growth signal, essentially an acceleration, like a broken accelerator on a car. And one of those would be the BRAF mutation in melanoma, which I'll talk about in a second. Another type of mutation is a tumor suppressor gene, where mutation results in loss of a growth inhibitory signal, kind of like the loss of brakes in a car. Other mutations exist, gatekeeper mutations, mutator mutations. Basic class of mutations that cause growth of a cancer would be called a driver mutation, and mutations that occur as a result of the cancerous changes would be called passenger mutations. Why is this important? Well, melanoma has phenomenal numbers of mutations. It was referred to as a shattered genome, with this showing the proportion. This is the slide here. Each of these little columns represents one person's tumor with melanoma. And what you see is that the number of mutations in a given bit of DNA is extraordinarily high with melanoma. 10 is a high number for most cancers. Some of these melanomas have 80 or 100 mutations. And within those mutations, most of them were in one gene called BRAF. Another proportion would be in a gene called NRAS. Now, interesting thing about the BRAF is what this will show here. This is a pathway that's most important for understanding treatment of advanced melanoma. Receptors on the surface of a cell will give signals through the NRAS protein, lead to activation of BRAF, and then downstream activation to other proteins, and eventually lead to growth of cells and abnormal growth. Now, if you have a normal pathway, the growth factor stimulates the receptor, it activates this pathway, and the cell grows when it should. And then when the growth factor goes away, the whole pathway goes back to a resting phase. It's like a switch that's turned on and then turns off appropriately. When you have a mutated BRAF protein, it's as if a switch is stuck on. So the cell is growing, giving these signals to the other proteins, regardless of whether it's supposed to be growing or not. And the importance of this in melanoma is that protein is involved in the growth of many melanomas. The mutations within it have been identified. They cause us a predictable change in the structure of the protein. So it's a driver mutation, and researchers were able to understand how the protein changed shape, and it was possible to design a drug that could be taken in a pill, fit right into that active part of the protein and shut it down. And what you see here up on the right is what happens if you treated cells with this mutation with the inhibitor. This shows the growth over time in an experimental model. What you're seeing here is the cells don't grow, whereas if they were not treated, they grow steadily. This shows another set of melanoma cells that did not have that mutation, and they grow regardless of whether you have this drug present. And this shows a principle of treatment of personalized medicine, which is selectivity. The drug works in the mutated cells. It doesn't affect the unmutated cells. And the benefits are dramatic. So these have led to, this was the first revolution in the treatment of advanced melanoma. And before I go into it, I want to step back and say, how does your doctor know that a treatment is helping? Well, they know it through a clinical trial. And this involves treatment of a group of people in a uniform way and seeing how they do. You can't tell if a treatment's working from treating one. You can tell from one person. You can't tell if it's going to work for the next person unless you have data from a group of people. Dr. Yorio is going to talk about this. And then the question would be, what do you measure when you decide how a treatment's working? What's the most important thing? Well, it's easy to measure the response rate when you look at a tumor. You can see that within 3 to 6 months. Then how long does the response last? Is it clinically meaningful? Does this treatment keep the cancer from progressing? How toxic or difficult is the tumor? How does it influence the overall survival? But note that this can be influenced by later treatments. Maybe the most important thing for a person facing a cancer is how long will you live and how will you feel from either the cancer or from the treatment. So let's see what BRAF mutations did. Treatment of BRAF mutations with BRAF inhibitors. Well, they led to a phenomenal decrease in the size of the tumor. This curve is what's called a waterfall plot, and it shows the results of treating, probably 500 people. Each person's tumor either grew or got smaller, and the curve here shows it getting smaller until even in some cases, it completely disappeared, decreased by 100%. No treatment for melanoma had ever had any benefit like this. And this treatment can lead to control of the melanoma over years. This curve shows the likelihood of being free of progression of the melanoma over months, 12 months, 24 months. And what you see is that people, and each time somebody progresses, this curve ticks down a little bit. So about 50% of people are free of progression for a year. And unfortunately, then it has come back in these people. But about 20% of people may be free of progression out to 5 years or longer. This is for treatment with a combination of the BRAF inhibitor and the MEK inhibitor. And MEK is this next step in that treatment pathway, in that signal pathway that I showed you. We give them together because two together, I'll go back a little bit, two together inhibit this and inhibit this, decreases the rate at which the cancers become resistant to the treatment. So giving them together. It's also possible, so this is a summary here. Who's more likely to have long-term benefit of this? People with a low LDH, which means their cancer is not growing quickly, who have just a single site of spread of the melanoma. We look at the overall survival of these treatments over time, but most people are treated with more than just one treatment. So it's hard to conclude how the BRAF inhibitor alone is affecting the overall survival. But we do know that it does reduce the risk of progression for at least a year in most people. Which ones to choose? There's 3 different combinations of BRAF and MEK inhibitors, and they all have about the same degree of effectiveness, about a 68-70% response rate, and duration of response is about the same. They differ somewhat in toxicity. Dabrafenib often causes fever that can be disabling. Vemurafenib can cause severe skin rash and diarrhea. Encorafenib can cause muscle aches and occasionally some eye changes. Often we try one, and if the toxicity is too high, we might change to another one. It's also possible to use these to prevent recurrence after surgery. And this is a slightly different approach. This is after removal of all the tumor, but knowing that it's a high risk of recurring, we can give these to prevent recurrence. Usually, the treatment to prevent recurrence is the use of immune therapy. And Dr. Wade is going to talk about this a little bit. However, if there's a rapidly growing tumor with a high LDH, or if a person has impaired immunity, the use of the BRAF inhibitors may be used to prevent recurrence. What we see is that it does prevent recurrence in many people. It's given for 1 year. That's this curve on the top in the blue. And then over the next year or two, there is a higher risk of recurrence. But still, out to 5 years, more people are free of recurrence who are treated with these treatments in comparison to people who did not have those treatments. Now, what Dr. McCain has pointed out in some of her previous talks is let's look a little bit at these segments. What is the value of our treatment? Well, these people who had recurrence we need to treat them better. We need to find better ways to treat. So about 40% of people, we need to have a better treatment to keep it from coming back. These people, about another 40% of people, did okay even without the treatment. So it's in that we've improved the odds by about 20%. Now, this is a substantial improvement. We need to do better. We need to be able to move this curve up and make it so that fewer and fewer people have recurrence. It prevents distant metastasis, generalized recurrence, and also distant metastasis. And so what else can we do? I'm going to review here. So we want to improve on this. So how could we improve it? Well, let's review again where the mutations are that we know. There's NRAS mutations. There's mutations in the BRAF protein, the one that we talked about. There's other mutations in the BRAF protein. There's mutations downstream of that in other proteins. One possibility is to target other BRAF mutations with naporafenib. That's a new agent which is under development. And if we look at that, we see that it also has the same benefit in terms of reducing the size of the tumor, but it's not as powerful as the BRAF inhibitor was. There's fewer people who have that profound reduction in the melanoma tumor size. There are agents that bind to the BRAF, to other mutations in BRAF. This is a summary. NRAS mutations are being looked at. Pan-RAF inhibitors will work against non-consensus BRAF mutations like I've shown here. Eye melanomas, which are a very different type of melanoma than skin melanomas, can be treated with agents that stimulate protein kinase C, that block that rather. Research now is looking into understanding the biology of the melanoma. What makes it grow? What makes it invade? Why does resistance develop? Why do melanomas get so much energy from sugar? And can we use that against them? Sometimes melanomas recur 10 years after the original tumor was removed. Where is it hiding in the body? Why doesn't it grow during that time? What makes it start to reappear and grow? I referred briefly above to other personalized medicine strategies, such as the use of antibody drug conjugates, in which a chemotherapy-loaded antibody will bind to a protein on the surface of the melanoma and then attack the melanoma. Studies are undergoing now with a TROP2 antibody drug conjugate. So I don't want to run too much time here. The problem we run into is that our treatments stop working within about a year in the case of BRAF inhibitors. And why does that happen? It happens because you have 10 million cells. And those cells that are sensitive stop growing, but unfortunately the cells that are resistant become a dominant population. So God, in designing melanoma care, God might be saying, only 1 year of benefit. What can we do to treat it better? Well, we know it's a disease of growth regulation. In some cancers, the key genes can be identified. In these few, the genes can be inhibited by drugs. What do we do? What if we wanted to know everything possible about a given cancer? What if we wanted to define all mutations which affected the coding regions of the genes involved in cancer? What we would do is we would sequence all the DNA. And this is what came out of the Human Genome Project back in 2000. And it was a revolution in our understanding of cancer. But unfortunately, there's still limits based on understanding all the genomic mutations in a cancer. Even if we know those mutations, we don't fully understand how they interact. The Human Genome Project really just gave us the parts list for a very complex organization of a cell. It didn't explain how everything works together. And what you see is that growth control pathways are incredibly complex and interactive. This is just for one growth control system. There are dozens of other growth control systems. So it's a bewildering degree of complexity. Also, there's another problem. The gene mutations we can treat with targeted therapies are mutations that activate proteins and cause abnormal growth, like the struck accelerator in a car. So we can give a drug that turns off that growth. But most mutations that cause cancer are in tumor suppressor genes, where the mutation essentially inactivates a growth control gene, kind of like the brakes failing on a car. And the problem with that is that we don't have a good way to replace a failing gene or replace its function. Also, even if we did replace the gene and made that cell grow more slowly, that cell would then be outgrown by any resistant cells, which did not respond to the replacement of the tumor suppressor gene. So presented with this complex and terrible picture of a much more wily and evil cancer cell than our poor brains can deal with, what can we do about it? Well, one solution is this. As cancer cells grow faster, become more resistant to treatment, they also become more mutated. Their genes and proteins become more abnormal. The cells become bizarre and weird. Well, then they may be more visible to the immune system if only the immune system can be awakened. And Dr. Wade is going to talk to you a little bit about that and how that can be done. So I wanted to briefly, before I leave this, talk about another aspect of personalized treatment, which would be the person. We were talking all about the unique characters of the cancer. What about you, the person being treated? Well, we know how to treat based on clinical trials, which are treatments for a group of people, all with uniform characteristics. If a doc proposes a treatment for you, you should ask, how well does a clinical trial match my case? For example, stage 4 melanoma can be very extensive disease, or it can be just a single distant metastasis. Did the treatments work the same for people with extensive disease or oligometastatic disease? What strengths and vulnerabilities do I bring to the treatment? If I have an autoimmune disease or an immunosuppressive treatment, immune therapy may not be safe or effective. Then maybe targeted therapy would be better. My body may respond in very different ways. Research now is looking at how the bacteria in your gut may influence how you respond to immune therapy. And research is going on that. What choice would you make as a person? Would you choose a more toxic treatment if it increases the chances of remission, or would you wish to minimize toxicity and minimize risk? A choice you have to make in talking to your doctor or your practitioner. Are there aspects of your care that fall outside of our clinical trial knowledge base? Clinical trials look at a uniform population of patients and are very valuable in defining what treatments to do, but they can be blunt instruments. They may not fully account for prior treatment. They may not account for the fact that somebody has a single metastasis that can be treated with radiation or a brain metastasis. Also, how do you respond? How do you respond to the treatment? How does that guide what you should do? How long should you be treated? When should you change treatment? Are you having a response on X-rays, shrinkage of tumor, or is it possible that you're having not much response on X-rays, but your tumor is shrinking down when we biopsy it? And we certainly see this in melanomas. So all of these are questions that you should bring to your doctor when they talk to you about treatment, essentially part of the art of medicine, helped by clinical trials, helped by our understanding of the biology of the cancer. And I'll stop now. So thank you for listening and giving me the chance to think this through.
Well, thanks, Dr. Amatruda. That was fantastic. I loved, we always talk about how these pathways are just so simple, right? It's just one thing to the next. And so I loved that picture of just actually showing like for every, cause, there's a reaction, and things are certainly more complex. And then I think you're right. We have all these trials, but what does that mean for you as the patient, and your discussions with your doctors?